Thank you. Thanks for inviting me to speak to you all tonight, and I appreciate everybody coming out on a Thursday night. This was a letter that I received on 4/11/15. Dear Michael, I recently saw the article in the paper about your book, The Hospitalist, and I want to offer you my congratulations. For the past 10 years, I have complained about the arrangement where your doctor will see you when you are well, but not when you are sick. It caused me to retire earlier than I had planned. I applaud you for putting this in print so the public can understand the problem. And I would like to read your book. How can I get a copy? So this was a doctor who I had known in Plano and who had been in practice for about 30 years. And he saw and read about what the book was about. He realized that that is what the main part of why he had retired early, and he felt it was important to get in touch with me. I'd like to start out, though, by telling you what made me become a doctor, what influenced me. And it was my pediatrician first. I grew up in Huntington, West Virginia. Most people probably don't know that much about Huntington, West Virginia, other than Marshall University is located there. And Marshall University, when I was 11 years old in 1970, that was the site of the plane crash, the largest plane crash athletic team ever killed. The whole football team was wiped out. And some of my friends became orphans at that time because their parents, they had a lot of the boosters were on that plane. But I was a very sick child growing up. I was constantly in the hospital. When I wasn't in the hospital, the pediatrician was coming to my house to see me. And his name is Dr. Robert Kopp. And Dr. Kopp was a polio victim and was paralyzed on the left side. We had a 2-story house. And a lot of times I was too sick to leave my bed on the 2nd floor to come down to the 1st floor so he could examine me. He would make house calls after he finished his day seeing patients in the office. So he would take his bag, his doctor's bag, under his arm, and then pull himself up at the banister, pulling his side up that he couldn't move, and one leg at a time, and come up to the 2nd floor to see me. I never saw him do this, but my dad would describe it to me, and my parents spoke about him with tremendous reverence. They said, this is a doctor, this is the way doctors are, and this is the way doctors take care of patients. He was the first person that influenced me, and from the time I was 6, I said I wanted to be a doctor. They couldn't get me well, though. So I was sent to Boston Children's Hospital, which at the time, it was the top children's hospital in the country, and it's still one of the top children's hospitals in the country. And I spent 2 weeks there. It made an incredible impression on me. I could still remember it, even though it was 50 years ago. They did everything they could to try to make the children better. But not only that, they did everything they could to try to make the children feel good, feel at home, feel better. One night there was a knock on my door, and opened the door, and it was the Lone Ranger. The actual Lone Ranger had come to sign autographs and to meet the children. Another day they had Miss America there, and she actually was doing a television show from Boston and actually asked me to be on the show and be part of the show. But I spent 2 weeks there. My roommate was a 10-year-old boy who had a brain tumor. And the last night I was there, I was getting ready to leave. The surgeons were in the room getting ready to talk to him and his family. And I remember him saying, as they were escorting me out of the room because they didn't want me to be in there, I remember him screaming and crying, I don't want to die. So I had a lot of experiences as a child that basically said to me, this is what I want to do for a living. And this is the profession that I want to be in. When I was in college at Vanderbilt, I volunteered in the oncology clinic every day. One day a week for the entire 4 years that I was there. So I got to know the oncologists at Vanderbilt and enjoyed taking care of the patients. Even bringing the patients a glass of water made them feel better. Even doing this, taking their vital signs, whatever I could do, I did to help. And then I did summer jobs in the operating room of a hospital where I was an orderly and got to see that side of medicine, see the surgical side of medicine, and thoroughly enjoy that. So I was influenced early on to become a doctor, and then the subsequent experiences that I had were positive. Really did not have any negative experiences at all. What about writing? What made me become a writer? I've always written. I published my first poem when I was 9 years old, and actually the poem is in my book. I was able to work it in. In high school, I wrote mainly just for my own pleasure. In college, I wrote for the literary magazine that they had at Vanderbilt. Not as much as I would have liked to, just because of differences of opinions with the editors. I did write at Vanderbilt. They have freshman seminars that you can do if you've gotten AP credit and you're AP'd out of a course. You can take a freshman seminar, and I did one in English literature, actually in Gothic English literature, and then you can write a paper at the end, and the Phi Beta Kappa Society judges them, and I won the award as having the top paper of my freshman year at Vanderbilt. After that, I continued to do writing, but then I decided in the early 1990s, I started having a problem with what I saw as the way medicine had changed. And I would come home at night and complain to my wife. I said, this really isn't the way I thought medicine was going to be like. Well, what do you mean? Well, it started off as just a trickle in that a few doctors decided they would no longer come to the hospital to take care of their patients. And actually, these few doctors in my sphere were specialists. They weren't actually internists or family doctors, they were specialists. But then the trickle became a pour. And the doctors taking care of patients in the hospital became hospitalists. And these were doctors that did not have private practices, but instead were only your doctor when you became sick and were in the hospital. And it became more and more, so that initially at my hospital there was one, then there was two, and most of the other doctors that had practices would still come to the hospital. But eventually it turned out that almost no doctors that had practices that took care of you when you were well would take care of you when you were sick. There was a tremendous dichotomy. It seemed to me like when you would need a doctor the most and want them the most, they were nowhere around. And so my outlet had always been writing. And I always felt poetry was the outflow of powerful feelings, but I couldn't capture everything that I wanted to say in a poem. So I started writing this novel, The Hospitalist. And more and more had interactions with the hospitalists, found out that almost always they did not know the patient when they came to the hospital. And unfortunately, a high percentage of the time did not take the necessary steps to find out what needed to be found out. If there were records, things like that, I would be the one that would be having to obtain these records. I would be the one having to do the different things that normally the doctor who is the main doctor for the patient would do. It seemed like these hospitalists would consult. The patient would come in with a heart attack, but they may have a little bit of nausea, they would consult Dr. Weisberg from GI, even though it really wasn't something. It seemed like the more consultants were on the case, the less the hospitalist was involved, and the hospitalist almost became like an intern. When you start medical training after you finish medical school as an intern, you're mainly just almost like keeping score. You're mainly doing the history and physical exam, doing the discharge summary, but not really taking care of the patients. And that seemed to be the role that the hospitalists evolved into. The other thing was that it didn't seem like the hospitalists that I was working with were being vetted the way the doctors in the community had been. A lot of the hospitalists would be there for 2 months and then they'd go and no one, what happened? We don't know. There's the next hospitalist. Who are they? We don't know them. So it seemed like the turnover with the hospitalists was great. So again, the people that seemed to be taking these jobs, some of them were great, but there was a tremendous spectrum of how good they were. And I didn't get the chance to pick who I'd work with like I would in private practice. I was basically, this is the hospitalist, this is the person who's assigned to take charge of the patient, and you're working with that person. I think that over time, when I originally wrote the book, I initially called it the state of the art, because I'd always thought of medicine as an art rather than a science. You learn the science, you went through medical school, you went through training residency. In order to learn the science to be able to practice medicine, you had the knowledge, but you had to have the art too. New England Journal this week just had an article yesterday saying about how they're looking at medical students and new ways of training medical students and making them now on the MCATs take sociology, and there's a psychology part, because it seems as though the doctors aren't able to relate to their patients anymore. And the art of medicine, I felt, had changed so significantly mainly with the hospitalist, with the doctors taking care of you now who knew nothing about you, but other things also, which I go into the book. So I started off with the book being the state of the art. I have a friend who's an author and a drama professor, and I had him read the book first. And he said, I love the book, I love what you've written, but the one thing in this book that's different from other books, medical books, is the hospitalist. No one's ever talked about that. No one's ever said anything about that. These other things you talk about, the insurance company, he said, you need to switch your focus to the hospitalist. So I rewrote the book. This was the second time that I'd written it, and talked more about the hospitalist, more of background, more of his, and really made him, rather than the central character being a gastroenterologist about my size, kind of looks like me, etc., changed it to be kind of an even, so you're seeing things in the narrative both from my standpoint, but also from the hospitalist standpoint. And also I changed the name of the book to The Hospitalist. I put it down for a while. This was in approximately 2004, and didn't work on it for a while, and did some other things. And then I have a boyhood friend who's an author who found out about the book and asked to read it, and he said, this book needs to be published, but you need to make changes. Everybody who edits says you ask people for their help, they're gonna say they need changes. And so I said, okay. So he told me what he thought, and we spent time. He lives in Cincinnati, so it was all done via text, by phone. And finally, I sent it to him, and he said, let's publish it. And so we decided to publish it. He actually designed the cover also of the book. So he designed the cover. And so we decided to publish the book, and so we published it in December. So that's a little bit about how the book came about. The book begins and ends, though, with the insurance companies, with letters of denial from insurance companies. So I don't look at the doctors in the book, any of them, as being good or bad, black or white. I paint a mixed picture because I think that's the way all of us are. We're human beings. So, but I do think that the insurance companies are the problem. And I think that they set it out, they're the ones that by changing the practice of medicine made it a fertile ground for the hospitalists to come. How did they do that? They squeezed the doctor's payments. We were talking before that we get paid about 40% of what we got paid 25 years ago. So when your reimbursement is decreased to that degree, you're going to look for other ways to make money or to keep your salary. You're used to a salary, you're used to a certain lifestyle, whatever, kids in private schools. And I think the way a lot of doctors decided to do that was to increase their office practices, increase the number of patients that they would see. Whereas when I started practice, an internist might see 12 to 15 patients a day. Some now see 40 to 50. And a lot of them have nurse practitioners and PAs working for them, so that you're not actually even seeing a doctor, you're actually seeing a physician extender. And so I think that the insurance companies, if you were to say to me, who is it that's the bad guy? If there's a bad guy in my novel, I would say that the doctors pass through the novel, you see them, you see their influences, you see what they do, you see how they change, but the insurance companies are the ones that drive things. And that's why the book starts and the book ends with letters from the insurance company. There's a thing called peer-to-peer review. Not only do they squeeze doctors financially, but the insurance companies take your time away. They basically tell you, hey, Dr. Weisberg, I think that patient doesn't need a CT scan. We're not going to pay for it unless you call our doctor and talk to him. And then you call the doctor and they put you on hold for 10 minutes, and then someone else comes on the line and says, well, that doctor's busy. And so after about 20 minutes, you eventually talk to someone who's usually not a doctor. If they are a doctor, they're not a doctor in your field. You explain to them in terms about why you feel a certain test needs to be done. And then usually they'll say, okay, we'll let it be done. But still, you've gone through 20 minutes of your precious time to try to get that done for the patient. I think there are other areas of medicine that are in the book that I talk about, and I'm just going to mention briefly that I found that I never realized this was the way things were. One of them is radiology. And the radiology practice is set up in my hospital and as a monopoly. There's only one group there, and they decide who reads your x-rays. So it can be someone who I've never met before and who's just out of training and did a training, say, in pediatric neuro radiology, who's now looking at my CAT scan of the liver to tell me what that is. I don't get the choice. And if it's a weekend or a nighttime late at night, there's not other people around that I could talk to also. So that's mentioned in the book, and I talk about that in the book, and that actually plays a key role in what actually happens to one of the characters in the book. I talk about anesthesia, and I'm not trying to insult any doctors here. If you're in these fields, I've met a lot of the doctors here, but I'm just talking about my experiences. But anesthesia, when we had our children at the hospital, after we had the children, we received bills, large bills for the spinal for my wife. And I said, what's going on? I said, I thought we paid some. And they said, well, the anesthesia at the hospital is out of network. I said, well, why couldn't I get someone else who is in network to do the spinal to take care of my wife? Of course, my wife, if she's in pain, I'm not going to tell anybody to go away. I'm going to say, hey, do whatever you can to help her. And they said, well, we have it set up that the anesthesia, we only have one anesthesia group at the hospital, that they do the anesthesia. It works better that way, and we don't require them to take your insurance. So we were stuck. I talk about pathology. And I first found out about this again after we had the baby, our first baby, and we got a bill from the pathologist for $50 for a laboratory fee. And my wife said, well, all they did was a CBC, a blood count on me. That was the only laboratory that they did. And so I went and asked, I said, what does this mean? And they said, well, this is our laboratory fee. For us, maintaining the equipment and making sure everything's up to standard in the hospital laboratory, we get paid a certain amount for every blood test that's done in the hospital. And so I said, wow. I said, that's an amazing racket. Even now, there's other areas I could talk about. I went in to see an internist recently, someone new in the community, to try to introduce myself to them and tell them who I was and see if I get them to send me patients. And the sign up, as you walk in, there's a big sign right up above where the person sits who greets you, and it says, Botox injections done on Monday and Wednesday. This is an internal medicine office. So the hospitalist, that whole idea of hospitalist has changed, but the whole area, the whole practice of medicine has changed. And I've seen it over 25 years. You've seen it over 30 years. And I think it's important that the public understands it and realizes it. And you have to say, is this the way we want to continue? How would you fix the problem? I don't think it's fair to give a talk like this unless you come up with at least some ideas about what you would do to fix the problem. Excuse me? Yeah. What you do to fix the problem. And I think as far as the hospitalist problem, it can be fixed. And there are things that can be done to make things better for all of us. I divided it up into beginning, middle, and end. And by the way, I don't address this in the book. The book is a novel. The book isn't for instruction. This is just something that after thinking about this and working in the system now for 15 years and seeing where things go wrong, that I came up with. So in the beginning, first of all, I think the primary care doctors, your doctors, doctor that you know, that you think is wonderful, that smiles at you and talks to you and stuff, they need to be more involved when you get sick. When you go to the hospital, they need to make sure that your records follow you. No matter what time it is, there has to be some kind of system set up so if at 3 in the morning you're sick and have to be hospitalized, your records are right there. And I know that you've had a stroke 6 years ago rather than not even knowing that and taking you off the aspirin right away because you're bleeding, and I feel like that's the only thing that we need to do. There's people come into the hospital that are dying and then they're meeting their doctors for the first time. And I think if those doctors had more records and more information, they could do a much better job. I had a patient that was 49 years old, a woman that I'd taken care of for years, and she came into the hospital and had been having some kidney problems and was getting close to having to go on dialysis, had had the same doctor for a long time, and I went to go see her kind of as a social visit, but I knew she usually had GI complaints also, and I saw on the chart it said DNR, do not resuscitate. And so I said, why did you say you don't want to be resuscitated? I said, you're 49 years old, you're married, you have children. She started crying a little bit and said it was the hospitalist who had made her DNR. It wasn't her doctor who had taken care of her, who knew her. And she said, well, I was real upset and depressed and thinking about dialysis, and I was thinking I didn't want to live anymore. So she and I talked about it. This was about 10 years ago, and I said, we took the DNR off her chart. She never came to that she needed to be resuscitated. DNR means do not resuscitate. It never came that she needed to be resuscitated, that she needed to be brought back to life. But that patient is still alive now. She got a kidney transplant. And not only does she still have children, but she now has grandchildren. So the hospitalists had made that decision on their own just from talking to the patient, not having any background about what that patient's life was, what was going on, the support system that she had, et cetera. I think that the primary care doctors need to do a better job, or need to do any job of getting to know the hospitalists. They don't know them. I don't know them a lot of the times because they're new. They change, but they should know that when Dr. X is taking care of their patient, I know Dr. X, this is his usual mode of taking care of the patients, this is what they should know. Every month, the hospital should sponsor an interaction so that the hospital doctors who refuse to come to the hospital and who will no longer see you when you're sick, and the doctors who will take care of you when you're sick, come together and meet and know each other. So that when they call each other on the phone and say, hey, I need the records, or hey, it's a much more comfortable experience for both sides. Also, in my hospital, after 8 o'clock at night, there's not hospitalists, MDs on call, or not in the hospital. There's nurse practitioners. So you get to the hospital, you're admitted, you get there at 3 in the afternoon, you finally get to a bed at 10 o'clock at night, and the doctor that comes to see, or the person that comes to see you is a nurse practitioner. And you may not be seen by anybody until the next morning. That happened today, as a matter of fact. A patient was complaining that I saw today that she wasn't seen until about 10 o'clock this morning by a doctor. And I think that has to be changed. I think that there has to be, if you're going to go to this system where you're saying, we're not going to have your doctor there, we're going to have a substitute there, that substitute at least needs to be a doctor. What about in the middle? So I've talked about what I was beginning as far as the patient getting into the hospital and things like that. What about in the middle? I think it's important that the patient and the rest of us know who is the hospitalist. It's constantly changing. It's like a revolving ball. A lot of them work 7 days on, 7 days off, 3 days on, 3 days off, 12 hours. And I can call and a number, no answer. Well, I thought it was this person. Well, so a lot of times what you'll do is in the middle of the night, you'll get called and you'll call and it's the nurse practitioner is the only person you can talk to. The hospitalists do not give out cards. I forgot to bring my business cards, but the hospitalists, every patient that I see, I'm Michael Weisberg, here's my card. If you need me, this is a number you can call and you can get in touch with me or one of my partners 24/7. None of the hospitals at my hospital have cards, so none of them, patients don't know how to get in touch with them. And you ask the patient, who's your doctor? I don't know. He came and saw me and he said they're going to do this, and this, and he's going to have a gastroenterologist come see me, but I don't know who my doctor is. They need to know. And then on that card there needs to be a phone number so that that patient can get in touch with the hospitalist when they have problems. So that or the nurse also, so when the patient's blood pressure is high, the nurse doesn't call Dr. Weisberg. Or when the patient wants to do this or that has nothing to do with my field, just because my card is there and the patient knows me, they're not calling me. I think that one of the things that's lost with this whole hospital system is the camaraderie that used to exist in medicine. The doctors out in the community that don't come to the hospital, I'm 56, so I started off with one peer group and then another, but now the doctors say between 30 and 45, I don't know them. they never come to the hospital. I don't meet them. I've got to go to their office to try to meet them and talk to them. And I think that the camaraderie has been lost, and I think that a lot of times it's the hospitalists, I think that you don't know them, they don't know the other doctors well, and a lot of times they'll call the doctors who they do get to know and who they see in the hospital frequently. Gastroenterologists, we're always there. Cardiologists, you're always there. They'll call us and they'll call us frequently. But when other consults need to be called, a lot of times the hospitals don't do it. They're not comfortable doing that. An ear, nose, and throat specialist. This patient's playing, I had a patient who was bleeding from the back of their throat. They thought it was a GI bleed. I said, we need to get an ENT. I don't think ENT comes to the hospital. Yeah, they do. So I think that there has to be more, the camaraderie in medicine, the knowledge of each doctor knowing the other doctors has been lost. And I think a contributing factor to that also is the short amount of time that the hospitalists, a lot of them stay in the hospital before they move on. I think that if they were there more permanently, and some of them have been there 5, 6, 7, 8 years, those I've gotten to know, and those I think we're all more comfortable with. But I think the ones that are there for a short time and move on, those relationships are never established. Beginning, middle, end. The most important part, I feel, of where the hospital system fails is at discharge. When you're discharged from the hospitalist should call the primary care doctor. This isn't done. What the hospitalist does is dictates a discharge summary. They dictate a note saying, Indian discharge on this medicine, blah, blah, blah. Well, a lot of times that doesn't contain all the facts. And as a matter of fact, a lot of times that summary was dictated before even all the facts are there. So I think it should be the responsibility of the hospitalist to contact the primary care doctor. The hospitalist will write a plan on their discharge summary saying the patient's going to see Dr. Weisberg in 1 week. Well, I may be out of town in 1 week. So what's the patient supposed to do then? Patient's going to be discharged on these medications. Patients may not be able to afford these medications. A lot of times the patients are sent out on medications that they have no ability to, means to afford. So I think that there should be someone in charge of the discharge. And I think it should be a caseworker and a hospitalist. I think there should be one hospitalist that's their job, is for the first 2 weeks after the patients are discharged from the hospital. I know it's hundreds of patients, but those patients need to be tracked. That's the problem, is the readmission. There's an incredibly high rate of readmission to the hospital because the discharge wasn't done properly. The patient wasn't sent home on medicine that they could afford. They weren't given the right doctors to follow up with, the right timing to follow up with. So I think that could be improved by having a specific doctor take charge of the discharge and saying, okay, this is my area, this caseworker is my area, okay, they need to be in a nurse, okay, let's get them to a nursing home, let's look at this, let's look at that problem. My mother-in-law had vertigo and was in the hospital, and the emergency room doctor, she's 82 years old, and she lives by herself. And the emergency room doctor didn't want to admit her. And it was midnight, and I called him and I said, there's no way that we can take care of her at home. She can't get up, and with vertigo, everything's spinning around, and she lost her balance. She was also vomiting. So I finally convinced, my wife couldn't convince him because she's not a doctor, so she called me at midnight and she said, you've got to talk to him, doctor. I said, okay, I talked to him. So they admitted her and they sent her home the next day. So we don't need it. So she got home, and when she was at home, she fell a couple of times. And so we took her back to the hospital. No one followed up on her. No one told her do this, do that. She was given some medicine to take, but she was no better. So she fell a couple of times. So we took her back to the hospital, and she ended up being in the hospital for about a week. So I think that the discharge of the patient has to be completely looked at. And if you're a part of it, if it's your spouse, your parent, et cetera, it has to be clear to you that it's safe to take the patient home from the hospital. So I think that's the biggest area of emphasis. I think that if we're going to say that hospitalists are going to be here, which it looks like America has, no one's raised a word about it. I looked for other books called The Hospitalists or anything about it and couldn't find any other. So it looks like America, you have been willing to accept this without fighting it. I think it should be a specialty. And there should be residencies in hospitalists. I spent 90% of my residency in the hospital, at Ben Taub Hospital or at the Veterans Hospital. Only 10% was spent in an outpatient basis. So you're telling me that the doctors who train with me, who spent 90% of their time taking care of sick, hospitalized patients, no longer do that. Those doctors, if they're just going to have an office practice, They should be trained in office practice. That's what they should be done. The residency should be changed. And hospitalists should have a standardized residency, which I think they are doing someplace, because when we gave a talk elsewhere, one of the people in the audience said, well, my brother is in charge of the hospitalist training program at Barnes, and argued with me about several other points as well. So I think that these training should be standardized, and some of these things that I've said, not just regarding taking care of the patient, but the interaction, the interpersonal interactions have to be taught. And they have to understand that, okay, I'm their doctor in the hospital, I'm responsible, and I think that the patients have to have that feeling that this is a person that's going to take care of me. When my father fell and broke his hip, he's 89 now, but he broke his hip, and he got operated on, and then Saturday night I decided to better go check on him. I checked on him every day, but it was Saturday night, and the nurses were in his room, and I said, what's going on? And they said, your father's crazy. I said, gee, I know that my family's a little bit out there, but I don't think he's crazy. They said, and they were giving him Haldol. Well, what's the problem? Well, your father refuses to stay in bed. He just broke his hip, and he won't stay in bed. He keeps saying he has to go to the bathroom. I said, Dad, what's wrong? He said, Michael, I gotta pee. And so I said, there's something wrong here. I said, he's got a Foley catheter in. That's a tube that goes into the bladder, but it didn't seem like it was working. And I said, so, can't you do something? Is there some? No, it's not that. It's something wrong with him. He'd get up, go to the bathroom, couldn't pee, get back in bed. Every time it'd take 3 nurses to take him. He's a fairly big man. So finally, I said, wait a minute. So I started, who's this hospitalist? Called one number they gave me, called a second number, no one there. So when he was admitted to the hospital, I got the number of the doctor who has admitted him. I said, I want your cell phone number. And I called her, and this was at about 10 o'clock on a Saturday night, and she was lovely. And she said, it sounds like the Foley catheter isn't working. We'll have them take it out and put a new one in. Well, as it turned out, they'd put the catheter in but didn't put up the balloon. That was the problem. They never put up a balloon, so that there was no way for the catheter to work properly. And so only the urine was coming around outside the tube. And then they actually even moved my dad to a room closer to the nursing station because they thought he was so crazy. But then they came in, they decided that, they realized, because her telling them to do that. And so, like I said, for me, poetry is the expression of powerful feeling, no matter what the subject. Darkness enveloped the room except for the lighted numbers on the IV. Suddenly, a direct bright light lit up your face like an actor on stage, and the nurse emerged from behind the curtain and into the light, dangling the Foley catheter like a hose with her right hand. I held your head in my hands, firm, unseen tufts of hair pressing against my trembling fingers. Your whole body arched forward like a catapult as the pain from the catheter insertion began. You had been chanting Mama, Mama like a prayer in synagogue all night as you writhed in pain. Then Michael, Michael in unstoppable rhythm, your cadence matching the agonizing drip of urine from your penis. Now you screamed Michael to the entire ward as I quivered in fear as the act was being performed. I kissed your forehead grizzled by 87 years and tried to calm you with words I couldn't utter. You should never be treated like this. Yet the perpetual drip of urine all night and your constant threatening to get out of bed to go pee with your newly fixed broken hip made it the only solution. Your face now creased by agony. I couldn't recognize your familiar features. Michael, you screamed again and again. My ears wouldn't work. I turned them off. I focused on 87 years of my father, now racked by unthinkable pain. Yellow liquid finally appeared in the tube. The drill had entered the well of urine, and the tube in the bag, which had been sitting limply on the bed, quickly filled with yellow gold. Your body fell back onto the bed as though you had been shot. Immediately you snored in peaceful sleep as I removed my hands from cradling your head. So that was my personal experience with the hospitalists on a Saturday night. I think that there should be increased pay for taking care of sick patients. I think there should be incentives to go to the hospital, that these doctors should get paid more not less. When you're in a situation where it's 3 in the morning, I get called at 3 in the morning, someone's GI bleeding, you get called at 3 in the morning, someone's having an acute MI. Those are the situations where really being a doctor and being able to snap out from being asleep and in a dream state to being in reality and saving someone's life, that's what the insurance companies should value, and that's what America should value. I think that the cities themselves should set up healthcare systems. And I don't know how, I'm not in government, I'm not a politician, but I think that the middleman should be eliminated and that the cities themselves should look at dealing with the doctors and setting up their own healthcare systems. I know that there's big places like Cleveland Clinic, some of these big clinics that have done that, but I think that that's the answer. I think taking out the middleman, I don't think you need to have the CEO of an insurance company making $100 million a year. And I don't think you need to have all the tremendous number of levels in these insurance companies. I want to talk about one other issue, and there's a pain doctor here who I met. I didn't know he was going to be here, but there's this whole area now of chronic pain patients, PAIN patients that we're seeing. And I get asked to see them a lot for abdominal pain. Now, when I started in medicine 30 years ago, the only patients that got chronic pain medicine and chronic narcotics, Norco, Vicodin, things like that, were post-operative patients or cancer patients, patients who were going to die. That was it. If you came in and asked for narcotics otherwise, people thought you were a pain-seeking person and we would refuse to give it. But now we have a whole cohort out there of pain-seeking patients, people who come to the hospital looking for pain relief. And in my hospital, they give IV Dilaudid, which is the most powerful pain medicine. So we have these patients showing up again and again. I think that we as a society need to relook at this whole issue of narcotics given to pain, and I'd be interested in hearing your thoughts about that. This whole issue of narcotics being given on a chronic basis to people in their 20s and 30s. Disability, so they don't really, a lot of them have jobs, some do have jobs, but it affects their whole lives. They all have constipation, so they come to see me for constipation. But I think that this whole idea that because you have back pain, rather than finding the source and treating it, you're just going to give someone a lifetime of narcotics is wrong. And I think that's something that America needs to look at and that medicine needs to look at, and we haven't. So I think it all boils down to responsibility. I think it's responsibility. And I think that when I decided to become a doctor and went to medical school, I recognized that there was going to be a tremendous responsibility. I went to Baylor College of Medicine, Michael DeBakey was there, and you'd see these doctors, and the doctors were looked up to, and you really thought of them as great people, and they took tremendous responsibility. Michael DeBakey would take care of his patient. He wasn't operating when I was there, but he would still take care of the patients, see them, see the families. I think that medicine in some ways mirrors society. People don't take responsibility. It's not my fault. It's his fault. This is why I am. My parents weren't good to me when I was growing up. And I think a lot of it comes back to that people have to say, the buck stops here. And that's why I say that to the patient all the time. Buck stops here. I understand that. Okay, I know you got the problem. This is it. We're going to get you better. And I think that's the major change that needs to be made in medicine. Thank you for your attention.